The objective of this module is to describe the validation process for a trained rapid plan model. This process includes the following main steps. 1. Identify an independent set of validation patients. 2. Compare the clinical DVHs to the DVHs estimated by the rapid plan model. 3. Create a validation plan using the estimated DVHs and IMRT optimization objectives generated by the rapid plan model. 4. Compare the optimized validation DVHs to the DVHs estimated by the rapid plan model. 5. Compare the validation plan to the clinical plan. And 6. Evaluate the dose distribution in DVHs of the validation plan for clinical acceptability. Let's discuss these steps in more detail. First, identify an independent set of validation patients that are different from the patients that were used to train the model. It is important to select patients that are representative of the range of patient geometries, plan geometries, and plan prescriptions for which the model will be clinically used. In addition, the plan quality of the validation patients should also be assessed similarly to the training patients to ensure high-quality plans are used. This includes adequate PTV coverage and organ at-risk sparing. If possible, select patients with the same contouring guidelines and clinical goals as patients used to train the model that you are validating. In the situation where you are validating a model that was trained at another institution with different contouring and clinical guidelines, the validation process should be used to determine if the model results in achievable DVH estimates and clinically acceptable plans for your clinical practice. Once you have identified a set of validation patients, you will follow the same general procedure for each validation patient. Open the first validation patient. The first step is to compare the clinical DVHs to the estimated DVH range. Make a copy of your clinical plan and generate DVH estimates. I'm going to name this plan Tests for training purposes. In order to do this, enter the optimization dialog window and open the plan information drawer to ensure all parameters are properly set. This includes the prescription, treatment unit, energy, MLC, X and Y smoothing, and other necessary parameters. Then, open the Estimate DVH drawer and choose your rapid plan model. At this point, your model has not yet been published for clinical use, so you will select Show Unpublished Models. Ensure the correct prescription has been entered. Then map each model structure to the corresponding structure name in the current structure set, while validating auto-mapped structures were associated correctly. Any unmapped structures needed for this model are indicated at the bottom of the window. When all structures have been matched, select Generate Estimates and Objectives, and acknowledge the fact that your model is unpublished since the plan you are creating is to validate the model and not for clinical use. It might take several minutes to generate the estimates. Once it completes, review the estimated DVHs for any abnormalities and return to external beam planning. The next step is to compare the clinical DVHs to the estimated DVHs. As you can see, your clinical plan is no longer calculated when you exit the optimization dialog window. Currently, you cannot view the estimated DVHs in a plan comparison DVH. However, you can calculate the copy of your clinical plan with fixed MUs to view the clinical DVH versus the estimated DVH. I have already completed this step shown here. The purpose of this step is to ensure that the clinical DVHs fall within the DVH estimation range as in this example. You can also record the value of the estimated DVH and clinical DVH at specific DVH cut points that correspond to institution-specific clinical objectives, and compare the two values for all the validation patients in aggregate. Based on the statistics, it is expected that there will be some clinical DVHs that are either above or below the DVH estimation bounds. However, the validation process is meant to ensure that overall the rapid plan model accurately estimates an achievable DVH for a given structure for the majority of patients. The second step is to optimize a new plan using the estimated DVHs and model objectives generated from your trained rapid plan model. Let's use our test plan and return to the optimization dialog window. Let's first review the generated IMRT objectives and normal tissue objectives to ensure that they have been added correctly. If so, you can select Automatic Optimization Mode and Automatic Intermediate Dose, and the optimization dialog window will automatically close once the optimization is complete, and the plan will be calculated in external beam planning. At this point, start the optimization. During optimization, you can review the optimization progress using both the DVH plot and isodose lines shown in these two windows. In the interest of time, I'm going to cancel this optimization and use a validation plan that has been previously optimized and calculated for comparison. Once the validation plan has been optimized, you first want to evaluate whether or not the optimized DVHs fall within the DVH estimation range. You can do this by viewing the optimized validation DVHs versus the DVH estimation range in the DVH window. There are several situations to consider during this validation step. If the optimized DVHs easily meet the lower bound of the DVH estimation and the PTV is well covered, or the optimized DVHs never meet the upper bound of the DVH estimation and the PTV is not well covered for all validation patients, this might throw a red flag that your model is not estimating achievable DVHs. On the other hand, if the optimized DVH meets the lower bound of the DVH estimation at the expense of the PTV coverage, or the optimized DVHs never meet the upper bound of the DVH estimation, but the PTV is well covered for all patients, this might indicate that the rapid plan model optimization objectives should be modified to find an optimal balance between PTV coverage and organ at risk sparing in the model configuration workspace before continuing with the validation process. The next step is to compare the clinical plan and the validation plan in the plan evaluation workspace. It is suggested to evaluate the validation plan using both isodose lines and DVHs, as the DVHs do not always show the entire picture. For example, ensure there are no hotspots outside of the PTV in normal tissue and that the plan meets your clinical guidelines. In addition, evaluate the validation plan DVHs to ensure that they are within an acceptable range of the clinical plan DVHs for all clinical objectives. You can again record the value of the validation DVHs at the same DVH cut points as before and compare the values to the clinical and estimated DVHs. Sometimes it is not possible to meet the clinical objectives due to patient geometry, and in this case, it is important to ensure that the validation plan spares organ at risk as much as possible while maintaining PTV coverage. Repeat this process for all patients in the validation set. Once you have validated that your rapid plan model is generating high-quality, clinically acceptable plans, return to the DVH configuration workspace to publish your model for clinical use. Select the Publish button from the toolbar and enter your Eclipse password. The Publish icon will change from red to green, and the publishing event, including the current user and date, will be present in the publishing log here. The model will now be available for clinical use in the optimization dialog window.